So tonight we're having Dr. Steve Duffin present the medical management of caries, and he's going to introduce himself here in just a moment. This is going to be recorded, it's going to be videotaped, so he would like questions to be at the end, and if everyone can just kind of stay quiet through the recording, because it will be available on a website that he will be talking about, and it will be free for everyone. So if you want to view this at a later time, that will be available. So here is Dr. Steve Duffin.
Thank you very much. It's a pleasure to be here with you tonight and talk with you about the medical management of caries. I'm just curious how many in the audience have heard a lecture on this topic before? Oh, a few. Was I the one? Okay. So it is rather a new topic in our profession, and I hope that we'll be able to provide some valuable information for you tonight. So once again, Steve Duffin, and as a matter of some disclosures, I am the owner of Shoreview Dental, which is a general dental practice in Kaiser, Oregon. I'm also the dental director of Oral Health Outreach, which is an organization devoted to providing care for those who lack care, including children and seniors. I'm on the Quest panel of experts on new products, and I'm involved with research and development on a silver nitrate unit dose system. So that's who I am. I want to mention that all of the references tonight are available on this website. mmclibrary.com is a open access site that we've developed to collect all of the historical literature about this topic, and occasionally we'll post a symposium like today's lecture. So if you like what you hear tonight and you have friends that want to learn about this, it will be available to them. So the images that you see there are actually of the ADA library and also the Northwestern University archives, where the records of G.V. Black are held. A year ago, I went on a tour of most of the major dental centers around the country that have historical literature on this topic, because most of this information you will not find on Google. Okay. It was done a long time ago, and so we collected that information and put it on our website. I want to give a special thanks to the California Dental Association, who published my paper on this topic called Back to the Future, the Medical Management of Caries, in November of 2012. So we're a little over a year out from this publication. This, I believe, is the first time any attention was drawn to this subject for about 50 years, so it's been a long time.
I was expecting there to be a line. I was not expecting the line to have 1,000 people in it by 5:30 in the morning.
We came in here Sunday morning with volunteers to set this clinic up, and at 8:50 the first person got in line.
We were laying plumbing, electrical. We've brought in over 100 dental chairs. We have lights. We have, all of our drills, and we had to make all that work.
Well, we've been here all night, and I got to get my teeth fixed so I can eat.
I feel awesome about it because personally, with the economy the way it is, I haven't been able to find employment.
I've been dealing with abscesses for like years now, and I just don't have the opportunity to get them taken care of, so I'm really thankful.
2 semi-trucks full of equipment, tables, chairs, plastic covers for the tabletops, an entire x-ray operation. Patterson Dental brought in supplies. We got additional equipment for labs.
All I want for Christmas is my 3 front teeth. My 3 front teeth. My 3 front teeth. Thank you.
Just before dawn, volunteers greet the first of more than 1,000 people who had braved the long November night for a chance to see the dentist. The first Mission of Mercy free dental clinic on the West Coast had taken a year to plan, required equipment and supplies from all over the country, and the energy and skills of more than 1,200 people. Now up and running, it's immediately clear the need is greater than anybody expected.
Any number of people that are showing up here have dental problems that have gone untreated, you know, not for a week, for years. Things that are happening here are taking a lot of people out of pain, getting some people some help that they cannot get otherwise. We want every patient that comes in here to be treated with respect, and hopefully we're doing that.
The support has been unbelievable. We have sterilization, we have physicians here helping us, we have the nursing association is here. It's not just the dental community, we've really had to pull from other areas to get it to come off. Bring your head back just a little bit.
Once they're evaluated, each patient is escorted through the system. For most, X-ray comes first. 6 X-ray machines must do the job for a couple of thousand patients over the next 2 days. Nearby, hygienists clean teeth that have been neglected for years. One whole side of the room is devoted to getting patients numb and filling decayed teeth.
Dentistry-wise, we're seeing a whole range of unmet dental needs. A lot of extractions, a few fillings, a few cleanings, but just a lot of unattended care.
All dental disease is preventable, and that's the saddest part about seeing that many people in line.
While hundreds of patients wait their turn in the reception area, still more line up outside in the rain.
We've already had to go outside, unfortunately, and mark the 1,000 patient cutoff point for today, and also tell people that if they're waiting in line now, they're going to be waiting in line overnight to be here tomorrow morning at 5:30 to be in the Tuesday clinic. So it's just very obvious that the need is out there.
If you're going to wait outside in freezing temperatures for 24 hours, you want to go to the dentist.
It doesn't take long for the extraction area to get busy. Patients are numbed, then oral surgery teams remove their decayed and abscessed teeth. For many, it is the first time in years they're not in pain.
Came in, they took care of us pretty good, pretty quick. You know, I got my tooth pulled. I feel good, doesn't hurt no more. Well, I can't feel it right now, but we'll see.
It's been pretty neat to walk around and you know, hear the stories from the different patients. And you know, I was talking to one patient that, you know, has been in pain for 5 years, and even with gauze and blood coming out of her mouth, you know, she was able to look me in the eye and thank me for being here. And you know, it's pretty special. It gives me chills as we sit here and talk.
Nearby, dental lab technicians set up an assembly line. After making impressions, they go through the process of manufacturing partial dentures. It takes a couple of hours, but the result is more than worth the wait.
I haven't been able to smile for years without covering my mouth, and to actually be able to know that I'm going to have confidence now and be able to smile is great.
One of the things that we do at patient exit is have the patients write some remarks, and so let me share with you what this one says. This is a miracle for me. My teeth were broken out by domestic violence. For years I've covered my mouth when I smiled, or I didn't smile at all. I'm so grateful that I have this wonderful opportunity to smile freely again. This is what it's all about, helping people in need, restoring their self-confidence, allowing them to get back out in the community and be useful members and be free of pain.
Oregon Governor John Kitzhaber gets a tour of the Mission of Mercy Clinic from Project Chair Terry Barrichello.
See so many people in need who don't have the resources. I think the larger story here is the pent-up demand in Oregon for dental services, people who have not had appropriate prevention. And to me, this is a showcase for the need to invest in fluoridation and to education and to prevention.
For every $1 spent on prevention, you can save $5 in treatment cost. So to see what could have been stopped, it's heartbreaking.
Some patients bring their children who find themselves in a special section of the clinic just for kids. The Dental Foundation of Oregon's Tooth Taxi, which travels the state providing free dental screening and treatment, is also put into use. One of the Tooth Taxi's missions is education.
One of our goals is to give the kids a positive experience. They all get escorted, they watch cartoons while they're being treated, they get stickers when they're finished, they get a prize. We give all the kids a little packet so they get toothbrush, toothpaste, floss. We give them education as well. We hope that they take that home.
The final stops for these patients include post-operative care and education.
Every patient who makes it through our system ends up with brushing and flossing instructions, as well as information on what causes dental disease and the nutritional aspects of what can factor into it.
If it's something that maybe giving somebody a few front teeth is going to help them get back into the workforce, it's huge. We all know that a smile is worth so much, and many of these people don't have a smile.
If we can provide people not only the service to get them out of pain, but the education to prevent this for the next time, I think you've done something important today.
So I'd like to give recognition to everyone who participates in these kind of events. Mission of Mercy is becoming more prevalent around the United States. But my point here is to emphasize how bad the problem is in face of our efforts to address it. So what I'd like to say is, here we are 3 years later, 2013, Mission of Mercy. There still was 1,000 people waiting in line to get in. Thankfully, it wasn't raining and cold this year, but nonetheless, my question is the oral health of our citizens really improving if we conduct a Mission of Mercy once a year? We need to look at the problem more fundamentally, and I'm happy to be here talking to you all because I think you're the workforce that's going to provide the solution. So the Oregon Smile Survey is done every 5 years. This version came out in 2007. It looked at the time period between 2000 and 2005. Looks at caries rates in children grades 1, 2, and 3. So approximately age 6, 7, 8, 9 in that time frame. And in 2007, compared to the prior 5-year time period, there was a dramatic increase in caries as a problem. In terms of untreated decay, rampant decay, etc., we knew that decay was getting more prevalent among these children. So in 2012, a new Smile survey came out. And one of the key statistics that I found disturbing was the finding that in the demographic of Latino Hispanic children aged 6 to 9 in Oregon, 24% have rampant caries, as defined as 7 or more untreated cavities. So can you imagine that ocean of disease that is out there that is not being addressed using the tools that we have today? This report came out in 2007 from the Centers for Disease Control. You may have heard about it. It looks at very young children, ages 2 to 5, across the entire country. So it's not based on socioeconomic status or urban, rural, etc. So looking at caries rates in this very young population, this report showed that for the first time, caries is increasing in that population. Children 2, 3, and 4. Where do those children get treatment? And we all remember the Surgeon General's report, or have heard about the Surgeon General's report. I'm getting kind of old now. In 2000, the first official report from the Surgeon General on the oral health of Americans was released. And while the general consensus was that oral health is improving among Americans, we have fewer edentulous Americans, etc., the Surgeon General pointed out that there was a silent epidemic of dental disease going on underneath this, in the sense that low-income children, persons with disabilities, seniors, caries was catching up with us. So my point is that the silent epidemic is no longer silent. These are some more images from Missions of Mercy around the country. While I was studying this phenomenon of increased caries, in America I ran across this paper in 2009 that looked at global caries rates. So we know that caries is increasing in America. What's going on globally? The simple answer is the same thing, okay? Caries is getting worse right here at home, and it's getting worse around the country and around the world. In February 29th of 2012, a special report from Senator Bernie Sanders came out titled Dental Crisis in America. And the very next day, the cover story of the New York Times was preschoolers in surgery for a mouthful of cavities. Now, I went to dental school in the 70s. I would never have imagined that the cover story of the New York Times would be about increasing caries rates in young children with the need to take them to the hospital. When I entered the dental profession, we were just coming out of a period of time where dental caries was going down, largely because of water fluoridation and fluoridated toothpaste. People were getting healthier. In fact, when I went to dental school, I was wondering if I was going to have a job. And some of my classmates were thinking about maybe orthodontics or oral surgery, but maybe not restorative dentistry. Maybe we're going to end this pandemic of caries. So it is astonishing to me 30 years later that this is not true at all. In fact, the problem is getting worse. So simply stated, after decades of progress, the epidemiology of caries and all of the factors, which we'll try and touch on many of them tonight, are changing. So these are two images of an advanced state of dental caries, one in a very young child and one in an adult. And so what can we do to address this kind of problem? Disease rates are going up around the country, and access to care is going down. In fact, the top buzzword in the profession right now has to do with access to care, and I personally believe that you are a big part of solving that problem. Some of you may have heard about this story. A young girl this month in January died in Hawaii during a dental sedation restorative visit. And I don't mean to pretend that I am an authority on this case, okay, or want to judge the opinion of the dentist, but it's tragic, absolutely tragic, that a 3-year-old child who had no dental symptoms, who simply went to the dentist and was diagnosed as having 10 cavities and needing 3 baby root canals, was subjected to a sedation and invasive restorative procedures that resulted in her death. So that's why this is so important. I've been kind of passionate about this message before, but more for reasons of believing that we can do more to help more people, not because I'm afraid that people are going to die because we're not doing the right thing. But I now take that position. The reality is, in our profession, our treatment paradigm is upside down. We completely have reversed the priorities that we should have in place. And our reimbursement systems and everything are based along those lines. And I'd like to challenge all of us to come up with new ways to thinking about what our roles are and how we move people toward oral health. Which brings me to the Shoreview story. So prior to 2005, I was the dental director of the largest Medicaid dental care organization in Oregon. I had been for many years. I've been involved with public health dentistry almost all of my career, especially children's dentistry. I've done hospital dentistry. I've done sedations on adults and children. I'm familiar with this whole territory. And at that juncture in time, as I was always looking for more providers, I found myself driving around in Kaiser, Oregon, looking for a dentist who had contacted me to talk about becoming a provider, Medicaid panel provider. And the fact of the matter is I got lost, and I was driving around, and I found this building with a for rent sign on it. So something motivated me to park my car and walk inside, and I noticed an empty building with a beautiful view, and sort of in that very moment, and again, I was looking for a dental Medicaid provider in this particular zip code. That's what it came down to. But I felt inspired to become the person I was looking for. So at that juncture of time, I was frustrated with the bureaucracy of public health in Oregon. was frustrated with the management of our resources, and in the face of that, seeing increasing caries rates going on. So I decided to go back to the front lines. So I fired myself, and I opened this office. 3 months later, there we go. We have a great staff, and I decided to assign myself a couple of thousand Medicaid children that didn't have any access to care before. So can you imagine what happened? All right? So we have thousands of children that have had poor access to care. They've got a lot of dental disease. I open my doors, naively thinking that I can just do more fluoride varnishes and I'll try and prevent this disease using my understanding at the time. It was like an avalanche. Phone rang off the hook. Every morning we had 10 people standing in line trying to get in the office because they were in pain, very much like the Mission of Mercy. Within a few months, I had a waiting list to go to the OR of 3 to 4 months. And so it was sort of an apocalypse and a real eye-opener to put myself in front of this problem. So I felt that I was doing all the right things in 2005 to address this problem. So what are those things? How about motivational interviewing? Okay? Well, if we can convince our patients to change their behaviors, we have some hope of impacting the disease. We all know that. And maybe some of you have taken classes in motivational interviewing. I did. I took the long class. I believed it then. I still believe it. We did education on oral hygiene to every patient that came through the door, really put an emphasis on that. Dietary counseling, trying to figure out where the sugar is coming from, etc. Enhanced recall schedules. So the nice thing about setting up a practice in this way is that if I wanted to see a child more than 2 times a year, I could do that. And so I'm a big advocate for developing treatment plans based on the individual needs of the patients. Fluoride varnish, so we got a truckload of fluoride varnish. Everybody that walked through my door got fluoride varnish, whether they needed it or not. More fluoride varnish. Sealants, we sealed everything that we could see, okay? We started visiting the schools and Head Start programs nearby. I decided to start looking at some of the antimicrobials that have been used historically in dentistry. Before I went to dental school, I was a microbiologist. That's where my original training is in. And so I recognized that maybe we're not looking at this problem correctly. So I started using betadine and chlorhexidine, Head Start, WIC visits, school screenings. I felt like we were doing all the right things in 2005. So what was the result that I got? For the most high-risk children, almost nothing. It didn't work, okay? It really shocked me that the huge effort that we put into this population wasn't reaching everyone. It reached some of them, but not all of them. I think all of us in this room know that in America today, 80% of the dental disease is in 20% of the population. That's really astonishing, okay? So why is that? And we'll delve into that a little bit, but in my own experience in this practice, we treated everybody the same, but a certain minority of these kids still had massive dental disease. This is an image of a case that really turned me around and convinced me to go back into practice and try to understand this. This is a hospital case, so we were taking this child to the OR, and as you can see, they had massive dental disease. If you look carefully, you may notice that this child had been to the hospital before. In fact, this child had been to the hospital 18 months earlier and had all of their teeth fixed by a dentist under general anesthesia, okay? Because the factors that contribute to the disease were not impacted by this operative treatment, the disease came back. And so this child is in the OR for the second time. Now, this is a huge problem on a lot of different levels. One is the OR is the wrong place to be treating dental disease for otherwise healthy children. It's absolutely wrong, and the taxpayers are paying a great deal for that service. To have a child go back to the hospital again is an astonishing misuse of our resources. We now know that children exposed to general anesthetics at a very young age can suffer from cognitive deficits. I took children to the hospital for decades, thinking it was the very best thing that I could do for them. I had no idea. I knew that there was a small risk for an anesthetic accident, and I never had any, thankfully. But we now know that there is morbidity associated with every one of these cases, and we need to think more carefully about them. So my hint here, why did this not work? Okay, well, maybe the solution that we're applying doesn't match the problem that we're trying to fix. So I really have one more disclaimer. I only have one objective, and that objective is to end tooth decay. You know, we have all these meetings, we talk about increasing the number of sealants and the number of fluoride varnishes, try to get our physician partners to do fluoride varnishes in their offices, and this and that, and we even battle over water fluoridation, on and on and on, okay? How about ending tooth decay? Maybe we should put that in our mind and believe that it's possible. So what I'm talking to you about tonight can be summarized by this statement. My medical management of caries protocol is multifaceted, starts with a strong emphasis on primary prevention, but uses a combination of silver nitrate fluoride followed by fluoride varnish when cavities do develop. Okay? We've all heard Canberra. Okay? I'm a huge Canberra fan. I go to all the Canberra meetings. All of those things are wonderful. Okay? But in spite of that, we still have children getting cavities, and we need to do something differently. So again, medical management of caries. Usually when I ask how many people have heard of it, nobody has. I didn't have a class on the medical management of caries. Okay, I don't know that it's in any curriculum anywhere in any dental schools in America. Is it a legitimate topic? Well, I hope that at the end of tonight's presentation you will believe it is. And I'm challenging myself to share with you the evidence that this is important. So I think we'll start by examining where we've been as a profession. I know that in 2005, 2006, when I was facing every day this onslaught of dental disease and the frustration that I wasn't seeing the results that I wanted, it drew me back to looking at the literature of the dental profession, going back to 1840 when the first dental school was founded up to the present. This is an image that's taken on the deck of my office in Kaiser, and I'm reading a textbook written in 1908 by G.V. Black, who talks about the medical management of caries from way back then. So I'm going to show you some of the history that is embedded that we seem to have forgotten about largely in our profession. We're going to touch on these individuals. So left to right, W.D. Miller, G.V. Black, Percy Howe. These are the founding fathers of the dental profession. And the lower two individuals are microbiologists that have helped open our understanding of this disease and perhaps why we haven't cured it. So how many of you have heard of W.D. Miller? One or two hands, okay. This poor guy has been forgotten, okay? And he is just a remarkable individual. He is a dentist who went to Berlin, Germany, who completed training in medicine, got a PhD. He's a very academic individual who practiced dentistry and also practiced microbiology on the side. So he had a lab in his office, and while he wasn't filling teeth, he was studying tooth decay. Now, in the 1880s, when W.D. Miller was in Berlin, nobody really knew what caused cavities. There was a debate about whether it was caused by an inflammation inside the tooth or whether it was caused by an infection outside of the tooth. W.D. Miller his office was located not far from the laboratories of Robert Koch. Robert Koch is really the founding father of medical microbiology. That's where Koch's postulates come from. Robert Koch is the guy who figured out what causes cholera, tuberculosis, all of these major pandemics that have faced mankind, and identified the individual pathogen for each of these diseases. Well, as it turns out, here's an American dentist in the background working in Robert Koch's laboratory. And again, there aren't very many people that know this, and it's an amazing part of our history. So Koch's postulates have been the bedrock of medical microbiology for more than 100 years. And his postulates are based on the idea that there's a pathogen, and that unique pathogen causes a unique disease, and that pathogen finds its way via various vectors from one person to another, and that's how it gets transmitted. So W.D. Miller learned this firsthand, in the very laboratories where auger plates were being developed and all of this breakthrough information was happening. And W.D. Miller set out to find the real cause of tooth decay. And he proved that tooth decay is a bacterial infection. He wrote a monumental book in 1890, The Microorganisms of the Human Mouth, which I had the great pleasure of reading, and gained a great deal of respect for this individual. This is a little video from UCLA, from Wenwan Shi. This shows over time the buildup of oral biofilm on a slide. So this is a vastly accelerated video, okay? But this is exactly what happens in our own mouths. We brush, we floss, we go to the hygienist, we get our teeth all cleaned and set up, okay? Guess what? There are 2 or 3 bacteria left in your mouth, and within hours, they have become billions of bacteria. So we're in this constant battle with biofilm, aren't we? Okay? And that's just the reality of it. Now, W.D. Miller set out to find the unique pathogen that causes tooth decay. And he found more than 100 different species of bacteria in dental plaque, but he was unable to identify the one that is responsible for tooth decay, even though he tried to do that. Now, the technology of his time wasn't very sophisticated. We have a lot more tools today, but it doesn't change the fact that caries is not a single pathogen disease. So when I went to dental school, caries was thought to be caused by strep mutans and maybe lactobacillus, okay? We didn't know a whole lot about the physiology of biofilms. Well, I believe that one of the reasons we're in this dilemma today, we have all these resources posed to treat oral health problems, okay, and we're not making progress because we largely forget that this is a biofilm disease. It is not a single pathogen disease. We're not going to find a silver bullet for caries. So again, this manuscript from 1890 is really a masterpiece. As I mentioned, this presentation is going to be present on our website, www.mmclibrary.com. Well, if you want to read W.D. Miller's entire textbook from 1890, it has been digitized and it's on our library. So you don't even have to go to the library to get it. During my trip across the United States to collect archival documents, I visited the University of Michigan at Ann Arbor. W.D. Miller left Germany in 1807 to come back to the United States to become the dean of the University of Michigan Dental School. At that point in time, he was probably the most famous dentist in the world. He published extensively. Granted, G.V. Black and he didn't agree on everything, but nonetheless, he was on his way there, and sadly, he died of an appendicitis as a very young man, just before the era of antibiotics. I was able to go to the museum at the dental school there and see the actual microscope that he used in Berlin and where he did this landmark work. It was really remarkable. Now, if you distill everything down to one statement, what I discovered is that W.D. Miller identified the most effective antimicrobial agents of that time to treat caries. And the #1 most effective agent was mercury. Okay, none of us want to be rubbing mercury on our teeth. We know that. He knew that. The second most effective agent that he found was silver nitrate. And he published this in 1890. Now we come forward a little bit in time to G.V. Black and his landmark book, The Pathologies of the Hard Tissues of the Mouth, published in 1908. G.V. Black really described this method that I'm presenting to you in detail without the fluoride varnish. He knew it. His chapter on children's dentistry is a masterpiece. By the way, if you want to read this book by G.V. Black, once again, go to my library. The entire book has been digitized. It's there. You can read it yourself. You might want to skip to the chapter on the treatment of children's teeth. That's the masterpiece. So G.V. Black was really today's innovator. More than 100 years ago, he was telling us that we should treat dental caries as an infection and treat the infection with an antimicrobial agent. And what is that antimicrobial agent? Silver nitrate. He described that in 1908. The upper image is taken from his book. It shows a photograph of anterior decay in a young child who had been treated with silver nitrate. And G.V. Black pointed out that there is no reason in young children in deciduous teeth to continue to treat after you have arrested their disease. The lower image is from my practice in 2011. A child with advanced anterior decay that has been arrested with silver nitrate and requires no further treatment. It's interesting that 100 years apart, these images look exactly the same. Coming forward in time now to Percy Howe. I have to keep asking these questions. How many of you know about Percy Howe? Okay, no one this time. All right, I understand. So Percy Howe was a dentist in Boston, Massachusetts. He was also the founding research director of the Forsyth Institute. We all know about the Forsyth Institute, which is the preeminent dental research center on the earth today. Well, this is the guy who started it in Boston 100 years ago. Well, Percy Howe was such a strong advocate for the use of silver nitrate to arrest caries, as he had learned from W.D. Miller and G.V. Black, that if you wanted to order silver nitrate to treat caries in 1920, 1930, etc., you would have ordered Howe's solution. And I actually found this advertisement from an ADA journal, 1922, where it's advertising Howe's solution. Okay? Today, if you want to use silver nitrate to treat caries, you simply go to Henry Schein and order it. But this is a remarkable history that's embedded in our profession. Okay, I got to ask again. Weston Price. Nobody this thing. One for Weston Price. So Weston Price, again, remarkable individual, dentist, 1920s, 1930s, who decided to figure out why some people had more cavities than others. And so he went on this adventure all over the world on his own dime. I mean, he didn't have a grant to do this. And he was studying DMFTs, period, the prevalence of caries in different populations. Weston Price went on every continent. He went to Australia, to Africa, to South America, far reaches of Siberia, Alaska. He'd been everywhere. What's important is that he identified a one-to-one relationship between the incidence of caries and the proximity of the population he was studying to Western processed foods, sugar. Okay? So Weston Price really put the connection between caries and sugar intake. And his work is absolutely landmark. Remember that he was doing this really in the pre-scientific era. So if you read his book, you might hear some things that aren't really accepted today really well. So I would give him a little bit of leeway. But nonetheless, he was remarkable. So this is from his textbook. Okay? What he found is that remote populations had no tooth decay. or 0.5%. No dentists, no hygienists, no dental offices, no toothbrushes, no floss, no decay. What? Central Australia, Central Africa, the Amazon. Okay, when the further he went out, the less caries he saw. It's a remarkable finding. Now, what did he do when he came back to Ohio to be a dentist again? How did he treat caries? Dr. Price treated caries with silver nitrate, right here, after finding that caries was almost non-existent in these remote areas. So there's a long, very solid history of using silver nitrate in our profession to treat caries. This isn't new. So to jump forward just a little bit, 1928, Alexander Fleming discovers penicillin. It's an amazing story of an happy accident in his laboratory where he found that a contamination in his Petri dish somehow was inhibiting the growth of bacteria. And he followed that line of reasoning until he discovered penicillin. Penicillin really changed the world. I think most all of us have lived in an era where we don't know what it was like to not have antibiotics, okay? But in that other world, most people died of simple infections. You could cut your toe and die of septicemia. Medicine never was the same after the introduction of antibiotics. It really has been a miracle to the human race. So whenever I talk to medical groups, I always like to put this slide up there and say, let's say the patient comes into your office today and says, hey doc, will you please sew this up? And this is obviously an infected wound. Anybody here think that that would be a good idea to just sew that up? Maybe we should control the infection before we sew up the patient. So it's so black and white, so simple to understand in the medical scenario, all right? Let me ask you this. What is that? What do you see? A word? Anybody? An infection. Okay. That is a massive infection that is present in the mouth of a patient. So what do we say? What do we dentists say? Pass the drill. Okay? Let's solve it with a drill, or solve the biological problem with an engineering solution, which is the foundation of our misunderstanding and our problem. So where do all those bacteria go when you put a high-speed drill in there? Okay? Well, so maybe that's why we look like astronauts when we work in dental offices. All right? There's a better way to do this. Okay? Just pushing the bacteria deeper toward the pulp, etc., with high-speed drills isn't necessarily a great idea. So I want to introduce the medical management of caries is a concept that allows us to first and foremost control the infection. Control the infection, then move on to the restorative step. I'm not saying that the restorative steps aren't important or aren't necessary. It's just astonishing that we don't have, or we have left in our past, in our history, this concept of disinfection and controlling the infection before we move on to restorations. I've wondered why that is, and I've talked with many people about it. Why in 1950 did we forget about silver nitrate or quit using the techniques that we did before? And let me suggest a couple of ideas. I don't think anybody knows for sure. But in the 1950s, number one, Percy Howe, the biggest advocate for silver nitrate use, and by the way, he was ADA president in 1928, died. Okay. So his personality and his message sort of went away. In the 1950s, we had local anesthetics, we had high-speed drills, and we had cosmetic filling materials. And then last, we had third-party payers. So more money came into the system. So in my view, all of these factors caused us to move away from treating dental caries as infection toward a surgical solution. Bill Costerton is a medical microbiologist who passed away last year, so just recently. But he made an amazing discovery. This was published in the January 1978 issue of Scientific American. By the way, back on my website, if you want to read this paper, it's there. So Bill Costerton had been trained classically in microbiology, and so he knew how to grow all kinds of bugs and to take bacterial samples and culture them in the laboratory. And one day he said, you know what? We know how bacteria live in test tubes, but do we know how they live in nature? He asked this question about 1970. Okay, so we've had 100 years of microbiology from Robert Koch to Bill Costerton. We've been studying bacteria in artificial environments. Costerton said, where do they live in nature? Well, he found that bacteria in nature live in biofilms. They are not found in isolation. They are not found in monocultures. They are found in biofilms. He wrote this paper, How Bacteria Stick, and he described how this very complex community of bacteria come together and cooperate for resources and compete with one another and create this filmy, gummy stuff that we call plaque. And in fact, he used dental plaque as his model to describe biofilm in 1978. And now that's all we talk about is biofilm this and biofilm that. So it's useful to know where this came from, this discovery by Bill Costerton. So today, when we study and we look at the biofilm world, we realize that this is an extraordinarily complex community of unique species of bacteria that, in spite of our best efforts to control, continues to march on and cause problems. Our problems being caries, gingivitis, and periodontal disease. These are all biofilm diseases, so Koch's postulates do not apply. We need to come up with a more sophisticated way to face our adversary, so to speak. So the biofilm world is enormously complex. In the year 2000, Philip Marsh, who is a medical microbiologist in England, wrote a very important paper. So the title of his paper is, Are Dental Diseases Examples of Ecological Catastrophes? How many of you have read that paper? Would you be, compelled to read that paper based on the title? Maybe not. So this paper sat there ignored for a long, long time. But Philip Marsh explained exactly why we have caries and periodontal disease and gingivitis and these problems. It's because the biofilm, which in a healthy state does not cause disease, shifts and becomes pathologic. And we can understand what causes that shift and how to respond to it. Thank you very much. So the most recent literature on biofilm, and believe me, this is a very active area of research, and every month I look forward to getting my International Association of Dental Research journal so I can see what the latest, greatest is, okay? But the research that is being done shows us that we have to understand how these complex communities of bacteria cooperate and live together to be effective. So why have we not cured caries? We've been trying for more than 100 years, 140 years or so. We've been trying to cure caries, and we haven't done it, right? How much polio do we see in our community? No. How about plague? Is the plague still a problem? Or cholera, typhus, diphtheria, tuberculosis? Okay. Why is caries still with us? Okay. I would propose to you that we have not understood it. If we had understood caries, we would have cured it a long time ago. And there are many academics in the dental community that have voiced that, would agree with me. Okay? We have not understood the disease properly. Bruce Pastor is a microbiologist at the Forsyth Institute today, He's one of the preeminent dental researchers in the world, and I met with him several years ago and we were talking about caries, and he said, Steve, there are over 600 species. We now know that that's a larger number, probably 700-800 species of bacteria found in the mouth. Less than 1/2 have ever been cultured. That's astonishing. We know nothing about half the bacteria that live in our mouth. So is it any surprise that maybe we have not been more successful? We don't know anything about these pathogens. So we've got to learn about them and to move forward. So I like this statement by Karen Sokol Gutierrez, who is a pediatrician affiliated with Berkeley School of Public Health, who said, you know, caries is really a medical condition with a dental manifestation, right? So medical condition, classic bacterial transmissible disease that manifests in a dental way. Why don't we have the right kind of solutions? Well, I'm going to propose to you that we have had the right solution, we continue to have it, and it's the form of effective medicine to treat the infection that causes caries. So if we go back more than 100 years ago, we find once again W.D. Miller, G.B. Black, Percy Howe. What did they have in common? What was their message that they shared with us? Well, they all said the same thing. Use silver nitrate to arrest caries. Then move on to whatever else you want to do. So that's what they told us to do. Somehow we've forgotten most of that. So what do we use today? We use fluoride in a variety of forms, okay, water fluoridation, fluoride varnish, etc., lots of types of fluoride. We use chlorhexidine, okay, maybe all of you use chlorhexidine sometimes, patients with gingivitis. Betadine has been tried, xylitol. So we have a lot of, you know, antimicrobial agents that have been used to treat caries. So I would ask you, how effective are they? Does anybody in this room believe that these products are highly effective in controlling caries? Okay. No. So how do we know that? Well, we can go to the American Dental Association's Council on Scientific Affairs and look at the 2 review papers that have looked at the entire body of literature on the subject of non-fluoride caries preventive agents and fluoride preventive agents. Published in 2011 and very recently in 2013. Once again, these reviews are on our library if you care to read them. Okay? After exhaustive research and looking at the literature, what is the findings? How effective are these things? Not so effective. Okay? It's not that they're totally ineffective. They're not as effective as they need to be. Why is that? Because we keep drilling holes in teeth. We keep filling teeth. All right? So the tools that we have are not as effective as they need to be. So I want to introduce a new concept. Combination therapy using silver nitrate and fluoride varnish together. So we're sort of taking some of the wisdom from our past, Miller, G.B. Black, Percy Howe, etc., and we're combining it with something new, fluoride varnish, to come up with a treatment that is remarkably effective. I know that many of you thought you were coming to hear about silver fluoride tonight. So this isn't a lecture about silver fluoride, but I do want to address it for a moment. Silver fluoride is a product that is used outside of the United States. There's a wide body of literature about the effectiveness of silver fluoride. But I'm not going to spend much time talking about it. Why? Because it's not available for us. Now that may change at some time in the future, and people often ask me, well, what's better, silver fluoride or silver nitrate? The answer is, we don't know. No one has ever done that study, so it remains to be seen. So, can we legally order silver nitrate solution? I asked myself this question in 2006. Okay, I just simply opened up the Henry Schein catalog, and lo and behold, there's silver nitrate right there, available in their pharmaceutical section. So it's available to be ordered from Henry Schein. Okay. Where is it manufactured? Is it, an illegal, imported product? No, it's manufactured by Gordon Laboratories in Philadelphia, Pennsylvania, which is an FDA certified pharmaceutical company. It is dispensed under a prescription in America. It is used for a lot of different medical purposes, and it is used off-label for the control of caries, as I'm describing it to you, but we have a 100-year history of it being used in that way. So what is the FDA status of silver nitrate? It's an important question. Ironically, it has no status with the FDA because it's been around longer than the FDA has been. Okay? So when people ask you, is silver nitrate FDA approved for treatment of caries? Well, no. It's amazing if you go back and look at how many things you use every day in your office and find out if they're, quote, FDA approved. The FDA regulates the commerce of pharmaceuticals in this country, not the clinical application of them. So why do we need something different? The answer is the usual stuff isn't working, very simply. If it was, we wouldn't be needing to have a mission of mercy every year, right? Or maybe every month. We wouldn't need these other things. We need to look differently. So in my own practice, I began to look for ways of treating patients differently. And like W.D. Miller, I had a little microbiology lab in the back of my office, and I began growing oral bacteria and treating them with chlorhexidine and betadine and silver nitrate and all these different products. So I was looking in the laboratory and also looking at the clinical application. So what was I seeing in my practice? The vast majority of patients that I was seeing presented for their new patient exam with cavitated lesions. And many of these Medicaid children had advanced disease for their first visit to the dental office. So, how do we treat that? So, early on, I began to ask, what can we do differently? I'd like to say that I arrived at the perfect solution right off the bat. I didn't. With time, I finessed my protocol. When it didn't work, I asked why, and I removed the tooth and suctioned it and tried to understand so that I could change my protocol and so that we could arrive at something that was highly effective. So I fine-tuned this technique over time. It took maybe a year, year and a half to really start hitting on all the cylinders to understand how to do this. There are very specific steps. I'm going to show you a little video in a moment that shows exactly how it's done and how it's applied. Now, one of the side effects of arresting caries is that the lesion turns dark. Okay, now ironically, it was dark to begin with. Now it's darker. So you have to figure out how to message that to the parents, right? Because they often don't understand, well, the cavity got worse. No, the cavity died, okay? The dark cavity is a sign that the infection is gone. So we have to message that to patients and message it to our colleagues. This is an example of an arrested lesion on the facial of this tooth. Well, guess what? We also discovered that when lesions are arrested, we can restore them quickly and simply with no anesthetic. The tooth no longer is sensitive because the infection is gone. The pulpitis that was present when that cavity was there goes away, and so we're able, when necessary, to restore these teeth quickly and simply. Just imagine how happy children are to find out that I'm not going to give them a shot. It's a big plus. So simple atraumatic restorations with no local anesthesia are the standard care in my practice today. We hardly ever use local anesthesia for restorative procedures. In cases of large posterior cavitations, we have developed, and I was taught this by Jeff Knight, who's an Australian dentist and researcher, that when the infection is completely eradicated with silver nitrate, you can bond glass ionomer right on top of it. Now, if you told me this 10 years ago, I would have passed out at totally unethical and improper care. Well, we've done thousands of these, okay, and it works. It absolutely works. So if we need to get rid of a food trap or maintain space, we bond GIC right on top of the arrested lesion. I actually believe that this case represents the highest standard of care that we can provide for children with caries. This is a child that came in with pretty much occlusal caries in all their posterior teeth, okay? So all we did is put the child through a series of steps to arrest the caries, and then we placed a fluoride-releasing glass ionomer cement on top of that. We're done. Where this child would have been subjected either to the OR, to multiple quadrant dentistry, maybe with restraints, etc., we've cured this child of their disease atraumatically. Now, this is very technique sensitive, and I learned this the hard way. Okay, I had some failures and I had to ask why. So this technique that I'm going to describe to you is the result of years of practice and learning, and now it's also the result of many other dentists and scientists that are looking at this to fine-tune it. If you do it right, it really works. I think one of the main messages here is that you can start treatment today. The standard model is a patient comes to a dental office and gets an exam, get x-rays, maybe cleaning, figure out what's wrong, and then you come back for a series of appointments, right? Well, how many people don't come back? Okay, there's a certain percentage that miss out on this opportunity. So this protocol allows us to start treatment immediately. So in my office in Shoreview, everyone who walks through the front door who has caries, they walk out with silver nitrate on the caries. Okay? We want to begin treatment immediately. So to ponder, I apologize for these goofy photos of myself. I actually had to do this presentation remotely once, and so it helped to have something idea of who I was talking. Why have we not found the cure for caries? We need to ask ourselves that. Honestly, it's embarrassing that we have not. Okay, and I believe that the reason is because our paradigm, which I will call the restore and repair paradigm, has failed. Just doesn't work. If it worked, a person would go to the dentist and get a filling and never have another cavity, right? That's not true. Some people have more cavities than others, and for a lot of middle class to upper middle class patients in America, they don't have any cavities or they have no dental disease. But for those at most risk, they have massive amounts of dental disease. So let me ask you, for those patients, high risk for caries, is more dental floss going to solve the problem? Okay, for a child with 17 cavities in their mouth, shall we fix it with more dental floss or toothbrushes? Or, okay, it isn't going to work. I'm not saying it isn't important, okay? It is important. But it isn't going to solve that problem. How about get more drills? There's a lot of discussion in our profession about let's give drills to more people. Let's train more people to use drills. Let me suggest that I don't think that is the answer either. Okay, more of the same stuff. So, you know, what shall we do? My point is, doing more of the same things that didn't work before isn't going to help us. So this is sort of my quest for the answer to this problem, which took place over a number of years in my practice. It involved scientific investigations in the laboratory. It involved educating patients. It involved, you know, taking some patients to the hospital, etc. This is a quick little graphic that I'm not going to explain all the details of it. Just look at that top line. The blue line represents the number of patients that came to my practice between 2006 and 2011. In 2006, we had approximately 7,000 patient visits in our practice. Okay? In 2006, 32% of those visits had a restorative component, okay, which is in most dental offices, but most people, they go to the dentist, and you get a shot, and you get a drill, and you go out with a filling, 32% of patients at that time got that routine. In 2011, not only did we dramatically increase the number of patients going through our office, because this protocol allows us to see more patients because it's so quick and simple and easy, but we reduced the number of operative interventions to 12%. That was by increasing the preventive procedures and introducing the medical management of caries. In the same time frame, my hospital cases went to 0. Now, I'm not here to suggest that we can totally eliminate hospital dentistry, because there are people with special needs, certainly children with medical situations that are going to require the hospital, okay? But there's no reason to take healthy children to the hospital to get their teeth filled. And we have not done that for quite a few years. I want you to hear this little comment from a parent of a story. Okay, tell me about your son.
Well, Diego, his name is Diego, he's been doing pretty good. After Dr. Duffin saved him to go to the hospital for a large surgery, or maybe painful surgery. So after Dr. Duffin treated him with some, I don't know what kind of medicine he used, but he's been pretty good.
He knew, he signed a consent.
Good. So you think the medicine saved him from needing to go to the hospital?
Of course, yeah.
Wonderful news. Thank you.
Thank you.
So here's one case, we have many, where a child was mainlined to the OR who got diverted, and we were able to control all their caries using the medical management of caries and avoid that entire situation. So where's the evidence for this, right? You're just one guy. And a couple of years ago, I was the only guy. I was one guy. Yeah, there are more people talking about this. And yes, there is evidence. So I'm going to show you some of the evidence from my practice and describe it to you. So a couple of caveats. Number one, this is from my practice. This is clinical practice. This is not research. I have never claimed to be doing research. I'm not experimenting on anyone. This is fine-tuning of a clinical practice. These children were all treated in my clinic. I treated most of these children myself. I scored their baseline exams. My assistant extracted the data from the charts. Most, if not all, of these children received multiple treatments with silver nitrate. I decided in 2009 that we needed to get some data, because what I was seeing seemed like a miracle. It was just amazing. And just talking to people about it without data was not going to work. So I had a staff member go through our charts, and we did a randomization. So we took every 10th kid who was receiving medical management of caries, pulled that chart, okay? Then we did an audit of those children. How many cavities did they have? When did they start care? How many treatments did they receive? And what was the outcome? We found 106 children in this initial evaluation that had 567 lesions. So this is a typical Medicaid kid, hate to say it, 6, 7, 8 cavities in their mouths, okay? And we tracked these kids for up to 4 years. What we found is that 98% of these teeth that were treated with silver nitrate became arrested and stayed arrested for up to 4 years. It was absolutely remarkable. Never seen any kind of data like that before. Now, this was the original data set. We now have a much more sophisticated way of tracking our data. I want to give thanks to Dr. D. Robertson, who is an advocate for children's oral health. He's a retired Indian Health Service pediatrician who built this sophisticated database that allows us to track over time the efficacy of this model. So when we began using this tool, my point is we now have 97% caries arrest, okay, at 6 months, and 89% caries arrest at 1 year. And the reason it isn't 97% at 1 year is because we have done a couple of fillings, all right? Some of those moms aren't happy with big black spots on the facials of D, E, and F. So we do restorations. But my point is, this is absolutely astonishing data, astonishing data. Dr. Robertson is the founder of Quest that I mentioned to you that I'm involved with. There have been 4 symposiums conducted in the United States on severe early childhood caries, primarily in Native American populations. A conclusion that Dr. Robertson came up with at the symposium in 2010 is that 1, we have the public health infrastructure to control ECC. We have the clinics, we have the staff, we have everything we need to control ECC. What we do not have is the technology. Now, this was before I ever met him. He made this statement. And let me make the point right off the bat that this is my opinion, okay? This is Steve Duffin's opinion. But my opinion is that the missing technology that D. Robertson identified in 2010 is right here. It's silver nitrate plus fluoride varnish. It's absolutely astonishing in its ability to stop this disease. So who will this help the most? Well, it's going to help children, high-risk caries children. Medicaid populations definitely could have a great impact in the IHS world. And the other is seniors. One of the bigger problems that we're seeing on our horizon is root caries in seniors. Okay? More people have their teeth longer. Okay? More of them are taking medication that impacts their salivary quality of their saliva. And so we're seeing caries in those populations. So I believe that the solution can be delivered to these people, and I hope that this method will be more widely available in the future. We've treated thousands of patients with this protocol with no adverse outcomes, none. If you want to look at the potential toxicity and problems associated with use of silver nitrate, go to the library, MMC library. I've collected lots of papers on that very subject. Here's some images of arrested caries. Now, I wish that they turned white. Okay? No question about that. I wished it did. It doesn't, all right? It turns dark, but that is a signal that the infection has stopped. And I can tell you that when this stops, it stays like that for years, years and years. So, is this a controversial subject? Yes, it is. Okay? Whenever change comes, it causes some anxiety, especially in our profession right now. There's a lot of concern that this might cause changes that people aren't in complete agreement with. But I don't believe that that should stand in the way of us delivering the highest quality care we can for our patients. I want to share with you one really telling example. This is Italia. Italia suffered a spinal cord injury at birth. She was the most medically fragile child I've ever treated in my life. And this is not her first visit, this image. This is after a couple of visits. But Italia had never been to the dentist. She's 3 years old. Okay? She's on a respirator. By the way, during one of the visits in my office, the battery died on her respirator. And the caregiver ran out to the car to get to the spare battery. Wasn't there. We had to bag ventilate her. That's how medically fragile she was. When I got a chance to look in her mouth, guess what I found? Decay in all of her posterior teeth. So 7 years ago or 10 years ago, I would have immediately thought, we're going to have to treat Italia because she's not cooperative in the hospital. So I actually decided to call the outpatient surgical center where I worked, and I asked the anesthesiologist if Italia would be a candidate for general anesthesia, given her medical conditions. Guess what? No way. There's no way that she would have been treated in the hospital even. So what would you do? This is a quick little video showing the medicine.
It's okay, sweetie. It's okay. It's okay, honey. It's okay. Here's medicine. Yummy. Bubble gum.
That tastes good, boy.
So she wasn't completely happy, okay? But guess what? we were able to treat all of her caries. Now, this was like a miracle. I was back at my office last year. I had not seen Natalia for 4 years. And lo and behold, she walks in. This is 4 years later. Okay? She's now gotten a lot better. She's no longer on a respirator. She's ambulating with a very complex sort of a walker. And she, again, we hadn't seen her for more than 3 years, came in for a checkup. Gave me an opportunity to interview Mom. But let me say, first of all of the lesions that we arrested 3.5 years earlier remained arrested. No change whatsoever. Okay? And she had no new caries. She now is 6.5, and she's ready for sealants. So all we did is rescheduled her to come back for a sealant appointment. But let's listen to Mom here.
So I am so happy to see Natalia here today, looking so good and so healthy. We've been able to treat her cavities with medicine over the past 3 years. No needles and no drills. Has that worked out pretty good?
Yeah, it has. It worked really good.
Is she a lot happier coming to the dentist now?
Yeah, the first time she came, she was crying quite a bit. And today we were all smiles, huh?
Yes, I remember that. This is a happy visit. Do you think this would work for other children? Yes, exactly. Well, thank you for coming to see us, both of you.
That's an amazing case. I'm so glad that we were able to treat her safely, atraumatically, control her disease, help her progress without subjecting her possibly to more trauma. We have a family that is driving to our office next Friday from Missouri, who is bringing their 2.5-year-old child that has been scheduled for general anesthesia and restorations that the mother didn't agree with. This family is willing to drive halfway across the country to receive treatment that is atraumatic and medically sound. We've had 4 cases in the past 4 years where children have come from Maine, from Baltimore, all over the country. Now we're adding Missouri because parents realize that our surgical paradigm is wrong. There's a better way to do it. So how does this work? Let me say that we could spend all week talking about this. And I'm only going to briefly touch on it, all right? It does work. And again, we've got a lot of literature on the MMC library that you can read about. But number one is that silver ion, free silver ion, not colloidal silver, not metallic silver, free silver ion is highly bactericidal. Free silver ion is able to penetrate the bacterial cell wall and membrane, enter the cytoplasm, it binds to ribosomes, it deactivates DNA synthetase, it kills the cell. So unlike some other agents that are bacteriostatic, this kills the bacteria. So silver ion, highly bactericidal. What about fluoride varnish? By adding the varnish immediately after the application of silver nitrate, we isolate the possibility of saliva contamination. In fact, I found early on that saliva contamination was the biggest barrier to success in this model of treatment. So we use fluoride varnish as a way to seal the silver ion into the lesion, and it also adds fluoride to the remineralization component. So those are the steps. The medical management of caries, is a reality in our practice. These are the steps. 1, apply an antimicrobial. 2, diet modifications, oral hygiene, remineralization, and what's last? Restorations when needed. Okay, what I've done is I've taken an upside down paradigm and put it right side up, right? This is the right path that we should be going through when we manage caries. So let's see the world through a child's eyes for a moment. So we have a little 3 or 4-year-old child going back into the operatory and they see that. How many children do you think want to jump into that chair? Okay, so how about that? That look a little easier? Okay. That second image is of all of the armamentarium you need to stop caries in the entire mouth of a child. Which tray would you select if you were the child or the parent? Should we get the one on the left or the one on the right? It's really that simple, okay? So for a tray setup for silver nitrate plus fluoride varnish, this is it. Now I would throw the Explorer away, and I have a nice little video showing me throwing the Explorer in the lake, but I won't subject you to that. You don't need an Explorer to do this, okay? We have a Daffin dish with one drop of silver nitrate can treat the entire mouth of a child. One drop. We're using tiny, tiny amounts here, plus the fluoride varnish. Step 1, apply the silver nitrate with a microbrush to a dried lesion. Step 2, apply fluoride varnish. This little video is going to show it in real time.
Open as big as you can. Ah! Good job. Open. Can you retract your cheek? Yeah, there you go.
Go ahead. Now watch this carefully on the last
Okay, open
tooth.
one more, okay? You're doing so good.
So there's some saliva contamination on that tooth. You can see it glisten. So the step stops, dries the tooth.
Good job.
Now the silver nitrate goes on.
Go ahead.
That's all there is to it. So over time, what I noticed is that we were successful stopping caries in every single case without using drills and needles, okay? We were able to atraumatically restore the teeth that were necessary, okay? We also discovered that these children did not get new cavities. I'm not talking about had fewer cavities. I mean, didn't get cavities. When we did that original data set of 106 children, and I was looking at the big spreadsheet, it came immediately apparent to me that we're missing the new cavities. Okay, these are the cavities when we started, and these are the treatments, and I've been doing Medicaid a long time. They all get new cavities, okay? And suddenly this cohort didn't get new cavities, so I challenged my assistant. I said, you forgot to write down the new cavities, right? And I'll never forget her looking at me and saying, there weren't any. I didn't believe it. We had to audit. We went back and did another audit. It's astonishing that we were able to extinguish the active decay and that there seemed to be a preventive effect here as well, which is not well understood, but we need to discover. So again, you've seen this image already. We're able to atraumatically restore these lesions. We're able to seal the silver nitrate in place, and this allows us to treat the whole family. Okay? It takes a few minutes to move a child through, and our protocol involves treatment with silver nitrate and fluoride varnish multiple times until we have a rest, so we can watch the whole thing. Okay? But instead of having a 45-minute appointment for one child to do a pulp and a stainless steel crown, in 45 minutes I can treat the entire family, including grandma who doesn't have OHP coverage. Okay? So one thing that I do know about the pathophysiology of biofilm diseases is you've got to treat the biofilm, and it isn't just on the tooth, it's in the whole family. Okay? You've got to be careful about selecting your cases. Silver nitrate is not a panacea. It will not solve problems when we have an irreversible pulpitis or we have a draining fistula. Okay? We have to catch the caries before it reaches the pulp. The application protocol is absolutely critical. So I'm just going to run a quick little video that shows you how the tray is set up.
So we're going to now show you how to do the tray setup. So we want to make sure we have all of our proper barriers on so that we're not getting any spray from any of the silver nitrate, because it does stain whatever it touches. So we're going to use glasses, gloves, a mask, and then of course our gown. And we're also going to use our tray. So we just have a basic tray set up with just the Explorer and the mirror and a 2x2 on it. You're also going to want an air water syringe so that you can properly dry off the area. We're going to have a fluoride varnish and just a little micro brush. So those are already on our tray. What I want to show you right now is how to put this into the actual DAPN dish. And we're going to use a pipette. Now we had it in a drawer because it is light sensitive. So we have a pipette, the DAPN dish, and the silver nitrate itself. Okay, so then we're going to open this up, and again, like I said, we'll keep everything on a barrier because it does stain. We use a pipette because it's kind of the easiest way to get it out of there. It brings up more than you actually need. So what we're going to do is we're just going to do one little drop like that. Stick it in there. We're going to put the remaining back because everything is clean that we're using. Screw this back on so we don't spill it. And put this right back here, and then we'll just pick up our barriers and the pipette that we use. Just throw everything away like that, and then you have a clean tray. Okay. Okay, we'll pop the bear, sweetie. Stay open. You're doing great. Good job. Stay open. All right. We take that medicine here. Doing great, a little bit more. Alright.
Notice how cooperative that patient is. That's wonderful. Not only are we being successful in controlling the disease, but we're gaining confidence in not creating dental phobics out of children, which is a very important part of this, in my view. The Declan story. I first met Declan when he was, I think, 3.5, might have been 4. He had rampant decay throughout his mouth, and we actually scheduled to take Declan to the hospital. So this was kind of before we were figuring out how to use silver nitrate. He was an obvious. Well, Declan, and we treated him with silver nitrate to just try and buy some time, okay? Declan lost coverage. He fell out, vanished. Okay, we didn't know what happened. Came back a couple of years later, okay, and he not only he had coverage again, but we discovered that all of his lesions, even though it's not very pretty, had not changed. Now, we've tracked Declan for almost 5 years now. All of those ugly primary teeth with black spots are coming out, and healthy permanent dentition is erupting into a mouth that does not have a pathogenic biofilm. It's a really great example. This is going to show how we do silver nitrate fluoride varnish in a lap exam and lap treatment with a very young child.
And you can kind of see where the enamel's wearing off before the decay starts. That's how it started with those other two. Yeah. You are such a good boy. You're doing so good.
By the way, this mother brought her child from Maine. State, Maine. So again, not very happy, but nothing dangerous is going on here. Okay? Nothing dangerous. The main concern about silver nitrate is protecting the eyes. Silver nitrate in the eye would be a bad thing. Getting it on your skin, leaves a stain, goes away in a few days. It's not a big deal at all. So we want to control the environment very carefully, especially with young children. Here's an example of treating root caries in a senior not long ago. In this case, the patient wouldn't even go into a treatment room. We had to treat her in the hallway. Okay, but we have a little portable air dryer. We're able to dry the root, apply the silver nitrate, and then apply the fluoride varnish. There we go. Treating root caries in an Alzheimer's center. That's all there is to it. Plaque control. This gentleman is a stroke patient who never brushed his teeth, ever. And I met him in 2006 when I opened my practice. And he would come in every 3 months. We would sedate him pretty strongly to get him into the chair. And if any of you have seen a patient who never brushes their teeth, maybe an institutionalized patient, special needs patients, so teeth are covered with plaque, you know, is acute gingivitis. And yes, I wish I'd taken the before photo, but I didn't. So anyway, every 6 months or so, we'd have to do some fillings, we'd have to do some more work, we would do a debridement, polish his teeth, he'd lose a gallon of blood. I mean, it was a nightmare, mess. After a couple of years, I gained some confidence using silver nitrate, and so I asked his wife, would it be okay if we just paint silver nitrate on all of his teeth? You know, I don't know whether the teeth will turn black, I don't know what'll happen, but will you let us do it? And why not? Why not? So this image of his dentition was taken 3 months after we did that. Now, I was so astonished. If you look very carefully, you might see some gray areas, some areas where the silver nitrate might have stained the cementum, you know, that kind of thing. But any sign of gingivitis? No. He had no plaque on his teeth. He had no gingivitis. He had no new caries. So I immediately asked, what did you do? I mean, who's brushing his teeth? No one. Did you change his diet? No. Okay. So this was almost 5 years ago. This gentleman still comes in. We see him now every 6 months. He has had no new decay. And we have stopped this pathology using medicine. So it's remarkable. Do we understand fully how this is working? No. There's more to be learned. So the medical management of caries is a reality. It's being done now. I want to take a quick trip to Seattle, and I want to introduce you to Dr. Burgess. Dr. Burgess, I met about 1.5 years ago. She was in an audience, much like your audience here. She heard my story. She later told me that she didn't believe anything I said. But you'll find out that she was prompted to give it a try, okay? Because nothing else was working. So who is Dr. Burgess? She is the dental director and chief of dental services for public health in Seattle, King County. She's the dental director of one of the largest FQHCs in Seattle. This is the presentation that she and I did together in Denver at NNOHA meeting in November of last year. By the way, this presentation by myself and Dr. Burgess is on the website. So if you want to hear her tell her own story in more detail, please go to the website, go to videos, NOAA Symposium 2013. So again, Dr. Burgess is responsible for 5 public health clinics, 2 jails clinics, mobile homeless dental clinics, school-based prevention team. Before she went into dentistry, she was a molecular biologist. She obtained a PhD and was a bench scientist, a real scientist, who decided that maybe she wanted to become a dentist and have a life, you know, or she had her own reasons for doing that. It was just astonishing that I would run into somebody with that kind of a scientific background who understood what I was saying and embraced this, okay? So after I gave this presentation, I asked her, you know, let's stay in touch, and she said, well, I'll let you know what happens. I couldn't really get her to come visit me or let me go visit her. Well, Dr. Burgess now has more than 1 year experience using this protocol, and she is uniquely qualified to assess whether it's working or not. She is using the database that I described earlier to track her outcomes, okay? She's saying that silver nitrate is a win-win approach, okay? So after starting silver nitrate, I do far fewer scoop and fill glass ionomers, operative fillings, stainless steel crowns. The kids like it, the parents like it, I like it. So I was very happy to hear her say that. More importantly, she's actually tracking the data in a scientific manner, since she is a scientist, which is kind of really nice to see. Well, at the symposium in September of last year that she and I both presented at, she presented her data Okay, so I think I mentioned to you earlier that my original data set showed 97% caries arrest. Her data set is showing 97% caries arrest. Identical. Okay, and this is what's really astonishing, is that I didn't know that she was doing this, but in the same time frame that she was implementing the silver nitrate caries arrest protocol, she's tracking how that impacted the rest of the practice. Now, I knew that we weren't taking kids to the hospital anymore, but I wasn't tracking how many fewer cavities we're doing, etc. This graph shows the number of stainless steel crowns being done in her clinic, which is primarily a children's clinic, over 1 year. Reduction of stainless steel crowns by 90%. Now, do we know that there's a cause and effect relationship? She'll be the first one to say no. Okay, we've got to figure that out. But here's the simple reality of it. Okay, implemented medical management of caries dramatically reduced one of the most invasive forms of dentistry that we offer to children. So I'd like to kind of wrap up by saying there is no evidence in the literature suggesting that there are any systemic toxic effects for using silver nitrate in the protocol that we've described to you. Okay? 1 drop of silver nitrate can't do anything. And just because someone goes to the internet and Googles silver nitrate and hears that it's maybe potentially a bad thing does not mean that it cannot do what we've described. There are more than 100 offices in the Northwest now using silver nitrate. And we are collecting data from some of them, and the data continues to come out exactly the same. Now, in order for this to become the standard of care in our communities, there probably need to be some changes happen. Okay? So I want to leave that challenge with you. Let's figure out what those changes are. Let's figure out how to deliver this care to the people that need it the most. And like Gandhi, I believe that you and I, must become that change that we wish to see in the world. And when we own it like that, it will happen. Thank you.